I'm gonna do this, and then I'm gonna do this. Can you guys see my slides? Let's see, thumbs up. Yes, great. Okay, folks, thanks so much for your time this afternoon. I'm gonna let my colleague on the presentation here introduce herself. You guys are very familiar with me. You met me before, but I'll let her do sort of proper introduction for herself. Today, we're here to talk about the intersection of HIV, substance use disorder, and MAT. We don't have any financial disclosures to share, but just so you're aware, we are sisters. We will try very hard to not keep our we'll try to keep our inside jokes out of this presentation. Otherwise, you can get a little lost, but I can't promise that they won't enter in there from time to time. In terms of our objectives today, the hope is that we plan on highlighting the similarities regarding barriers and stigma with substance use disorder and HIV. Specifically for this, keep in mind also what happens with patients who are experiencing both a substance use disorder and HIV at the same time. We want to outline potential drug-drug interactions between antiretroviral medications and MAT. We want to contextualize the utility of MAT as it applies to both HIV prevention and HIV treatment adherence. And then we want to highlight the importance of treatment referrals. And then how do we, even when you're not sisters with the opposite clinic, how do you figure out how to foster those partnerships to really best meet our patients where they're at? Sister, that's you.
Hey, look at us. I have to say, friends, my sister has called me many things over the years, but I think that's the first time she's referred to me as a colleague, and it gave me a little thrill inside. So my name is Annie Bear. I'm a registered nurse. I've been a clinical coordinator at the Positive Health Clinic for a little over 2 years now, but I've been with the program prior to that as an educator since 2012. I have a lot of different kinds of HIV experience in West Virginia. As you can see, I previously worked for a HOPWA agency, which is a housing and HIV advocacy program, and then also a medical case manager for a different slice of the Ryan White pie. I love what I do, and I'm exactly where I was meant to be, and I'm excited to have this conversation with you along with my sister today.
Yay, thanks for joining us. So I know we're talking to a room of addiction providers, addiction experts in here. I'm still going to review the definition here and what our goal for treatment is, specifically because I want to help highlight the similarities that you're going to notice then when my sister's doing the same for HIV. And so what we know about addiction, it's a treatable chronic mental disease involving complex interactions among brain circuits, the genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And so similar to other chronic diseases like diabetes or heart disease, there's periods of remission and then potential periods of relapse. Our treatment goals are not to expect the person to be cured from their addiction, but rather we're there to help them survive, to learn ways to manage their disease over time, and then to hopefully increase their quality of life.
So with HIV, again, just a little quick mini refresher. It's a chronic viral infection that, if left untreated, will result in a perpetual attacking of the immune system until a person passes away from any number of a handful of opportunistic infections. Antiretroviral therapy in this day and age is extremely successful and can afford the opportunity for people who are in care and have access to the medications a normal life expectancy. There's even successful medication now to prevent seroconversion or becoming infected with HIV if you're exposed to it. It's been used successfully for the prevention of HIV transmission among sexual partners, and they're starting to look at it for another layer of protection for people who share needles to inject drugs. But there's both pill form and injectable form to prevent HIV exposure. I think of it like putting on sunscreen to prevent a sunburn in case you come in contact with the sun's rays. Having these medications, these PrEP medications in your system, prevent developing HIV infection should you be exposed to the virus. Successful HIV treatment is really complicated by a lot of the stuff that Katie and I call and text each other about all the time, the complicated intersection between substance use and mental health needs that are going unaddressed. The biggest success for our patients, the biggest path to success for our patients is access to care and medications. It's all about medication adherence. So anytime substance use or mental health complicates that path, that's where we run into trouble.
Well said. So when looking at these two populations, or again, a population that's experiencing both, what we know is that they run into very similar issues with stigma. So one of the defining aspects of stigma with SUD is the person's beliefs about the causality. So what's caused this person to develop an addiction to substances? And there's the stigmatizing view that people choose to have this addiction. In addition, other similar viewpoints are that people with an addiction are undeserving of help, or that they don't want help to begin with, that they have a flawed character or poor morals, and that they are completely only depending on substances, and sort of only plan on depending on substances. And then my sister will go over the second.
Very similar to HIV, there's a lot of community and even some internalized stigma among patients themselves that their HIV infection is their fault. It's a result of poor choices or some type of lifestyle that they lived. That there's still an idea, particularly we battle with this in more rural parts of West Virginia, that only certain kinds of people have HIV, or that we don't have that around here. I hear that a lot from people, particularly in smaller towns or smaller communities, not just from community members, but also in healthcare facilities when folks aren't considering offering HIV testing or having conversations around PrEP with patients. It's because they don't understand the risk in their community to their folks, because they don't think HIV is in our small town. So that's a struggle.
Yeah. Let's talk about the impact of stigma on substance use disorder and the impact of stigma on HIV treatment. So for substance use disorder, what we know is that people fail to access or engage in treatment because of this fear of what people might think about them and how they're being labeled. We know the medical profession has at times failed to treat these folks appropriately, not using appropriate medications, not providing avenues for treatment. Some mental health programs may exclude specifically working with patients with addiction. Because of the stigmatizing views we just talked about, that sometimes then creates these public policies that are opposed to be able to provide people with help. Stigma is structurally enforced by laws that criminalize drug use and permit discrimination. And then for a lot of us, I think we've talked on these echo calls about these complex cases where if patients have a criminal history because of their use, this causes this future stigma, and they get stuck in this loophole of they can't access employment. If they can't get employment, they can't get their own housing, or they can't get loans to better their life, and they get sort of stuck in this downward spiral.
Very similarly with HIV, this is kind of more focusing on this internal stigma, but it's perceived community stigma is significantly associated with the internalized stigma. And I really like to bring this down to the very last bullet point. Because of that internalized stigma, that's associated, it can be in turn associated with lower medication adherence. And that's the key when we're talking about HIV treatment. That's what keeps people living with HIV healthy, and it keeps their viral load undetectable, which means that if they have an unprotected sexual partner, say, there's not a risk of passing it along. But it's really stigma. This is really one of those places where stigma impacts HIV care. And you see that in this, and I know that there's going to be a lot of similarities with mental health. The issues around stigma with mental health and HIV, you don't see with other chronic illnesses. You don't see internalized stigma necessarily with people who are struggling with high blood pressure or type 2 diabetes in the same way that people really carry a heavy burden with these two disease processes.
I feel like I call these our bummer slides. This is the last of our disappointing data slide. So let's talk about inequality at its harshest for both substance use disorder and HIV. So while much of the coverage of the opioid epidemic has focused on our white rural populations, what we do know is this epidemic affects white, Black, and Latinx people disproportionately. Overdose rates are rising more quickly among our communities of color. And then also overdoses among Native Americans are above the national average, and those rates continue to grow. Stigma makes it more difficult to receive compassionate, high-quality, evidence-based care. And racism makes this worse for our Black citizens. According to access to treatment really favors our white individuals much more, who are 35 times more likely to receive a prescription for buprenorphine. And then Black people are more likely to experience the negative legal outcomes for drug offenses. While approximately 14% of our US population is Black, they represent 29% of arrests for drug offenses, and 33% of people are incarcerated for drug offenses. And then lastly, more than half of those in state prisons and 2/3 of people awaiting sentencing in jail, they exhibit problematic substance use or meet the criteria for addiction. And what we know is white people with substance use disorders, while they serve jail time, they have more limited access to evidence-based treatments. Excuse me. Sister.
So very similarly along those lines, there's a disproportionate number of folks in the U.S. who are Black or Latino that are disproportionately affected by HIV. So initially, when the HIV epidemic kind of first made headlines in the 80s, it was identified in young, white, previously healthy men who partnered with men. Those cases have been able to, we've seen a trend in decrease from 2009 to 2018, but cases among Black or African American men who partner with men have leveled, and then they've also increased among Latino men. So there's evidence there that there are maybe communities that don't realize their risk or don't have access to healthcare, don't have access to PrEP clinics, or are aware of the risk within their community. Blacks and African Americans make up only 13% of the US population, but accounted for 43% of HIV-related deaths in 2018. That's significant because it indicates to me that you're talking about people that aren't being identified as living with HIV until potentially the end of the disease process. They're not identified until they're extremely sick and we're not able to get medication in them fast enough, or they are maybe aware of their status but have fallen out of care, don't have access to the care and treatment they need. We're in a southern, I think by most demographics, West Virginia is considered a southern state, and so we tend to fall along this. When you look at the state or the country in terms of HIV infections, we are part of this southern demographic that's seeing an increase in new HIV infections. Interestingly, for anybody that's into healthcare policy, it also very much mirrors the southern states that didn't accept the Medicaid expansion. Now, West Virginia did, so that's been helpful, but a lot of the other southern states that are really bearing the brunt of HIV infections did not accept the ACA Medicaid expansion, so there's even less healthcare access for people in the most vulnerable states. And then lastly, 40% of people living with HIV rely on Medicaid, but we know it's unequally accessible based on where you're living. So back in 2019, the U.S. Department of Health and Human Resources announced a very bold plan to reduce HIV infections by 90% by 2030. They called it the End the HIV Epidemic. A lot of us call it EHE for short. It's based on 4 key pillar strategies: diagnose, treat, prevent, and respond. And they really had all parties sort of seated at the table. A lot of times we see in other kinds of care services, sometimes there's a tendency for silos, right? You have this group and agency, but they're not talking to this group and agency, and there's kind of crossover a little bit, or duplication, or gaps in care. So this really brought everybody to the table, including HRSA, which is the Human Resources Service Administration, which is the administrator of the grants that our clinic works under, and then also SAMHSA. So we really kind of felt like the 2 pillars that we can talk about today, which are important, are the treat. So the idea that roughly 56% of all people living with HIV are virally suppressed. We're trying to get that up to 90%. So viral suppression is important because it's a signifier of access to care and access to medications. If a person's virally suppressed, they cannot transmit HIV to their sexual partners. There's a ton and lots and lots of research out there. It's a whole campaign called U equals U. It stands for undetectable equals untransmittable. We know that HIV primarily is transmitted by people who don't know their HIV status or are uncontrolled. So if we get those people identified, get them into care, we can really make significant improvements to that transmission rate. But when people are living with co-occurring substance use, we know that effective substance use treatment improves both the HIV outcomes and the substance use related outcomes. So we know that when people are in care, their overall outcomes are going to be better. In terms of the prevention goal, medication-assisted treatment can help prevent relapse and facilitate longer periods of abstinence. That means that they're more likely to be taking their medications. That's where I start to see my patients struggle, is when they relapse on substances, they fall out of their HIV care. Okay. Additionally, in 2020, so we know, right, nothing happened from 2019 to 2022 that would have taken our eye off the goal, right? Nothing at all. So COVID hurt us. COVID had people indoors. We saw big decreases across the country in HIV testing, but not what doesn't mean that there was not HIV transmission. So we're still playing catch up. But in 2022, the White House released their own HIV/AIDS strategy. So it followed along those same guidelines of trying to do a 90% decrease in HIV infections by 2030. Their goals and objectives were broader than those original 4 pillars I talked about. But I loved this. Goal 1.3.3, make HIV prevention services, including condoms, PrEP, PEP, and syringe service programs. This was the first time that I had seen HIV prevention, like federal documentation of this level, actually reference SSPs. And again, for you guys who are involved in like state policy, we know that's a step in the right direction, where like more like within our state, we've headed in a different direction. So goal 2.4.3 is talking about making sure that we're having a real collaborative effort to get folks screened for HIV, and then referrals when needed, and also including referrals to mental health and substance use. Anything we can do to keep HIV care is going to improve those outcomes. Addressing those intersecting factors of HIV, like Katie talked about, the social determinants of health, housing instability, mental health, trauma, substance use, and then certainly issues surrounding the safety and security of people, the LGBTQ plus community. And lastly, again, they talked about helping keep getting naloxone to people and educating people on the existence of fentanyl, and then facilitating linkages of substance use treatment and harm reduction programs, so folks have access to better care.
Oh, hold on, I want numbers.
Okay.
Oh, you know what? I'll admit I meant to take this slide out because this is old news for this group, but that's okay. I'll still sort of briefly,
But we're on the friends couch.
But well, we are on the friends couch. Oh, which I feel like is sad right now. So we all know medication-assisted treatment is the gold standard of treatment for opioid use disorder, and that every professional addiction society recommends using medications for opioid use disorder. The 3 specific medications, methadone, naltrexone, and buprenorphine, my sister's going to be able to talk about those interactions between those medications and the medications that she works with.
So if you guys were hoping for a really in-depth deep dive into pharmacology, I'm not your girl. This is not that kind of a talk. It's just very briefly, I wanted to talk about how antiretroviral medications are metabolized along a certain pathway, the same pathway that a lot of other medications in clinical use are used for. They can have 2 different kinds of effects on other meds. They can either inhibit the process of medications, which means those other meds can end up with high levels or have toxic amounts in the system and have toxic side effects, or they can be considered an inducer, which means they speed up the processing of those other medications and force them to be excreted more quickly. We actually use this to our advantage with 2 specific antiretrovirals, ritonavir and cobicistat. Taken at high doses, the ritonavir specifically makes people super duper sick. We used it originally back in the day at full dose, and it was terrible. But what they figured out is 1/3 of the dose makes a lovely little booster and makes the other medications work well. Where that comes into play on the next slide, it's a little bit less of a concern now, because the newer HIV drugs that we use tend to play nicely in the sand with lots of other meds. We don't see these kind of interactions, but you might still encounter a patient who's on a slightly older regimen. The big culprit for years was efavirenz, also called Sestiva. It can substantially lower methadone levels. A lot of times patients would say, my Sestiva is taking my methadone, or it's stealing my methadone. It meant that they were going to require higher doses of methadone to have the same effect. And when I talked about it with Katie, I said, Katie, what would it sound like if a patient came to you and said, I'm taking my medicines, but I'm still having cravings?
Oh, is this where I would answer? Yeah, they would. Sorry. Sorry. Yeah, they would talk about experiencing some of the cravings when they maybe stopped using substances to begin with. So having a hard time sleeping, feeling restless, nauseous, headaches, kind of flu-like symptoms.
But if you're listening to that as a prescriber or a practitioner or whatever, and you're saying, well, this dose should work for this patient, maybe they're not taking it, right? You can get into a little bit of maybe a miscommunication with the patient, not realizing that it's the drug interactions that are at play. The patient's taking the medicine, they're just not getting enough of it in their system because of this other medicine. Next slide. So buprenorphine, fortunately, it can act as both an inducer and an inhibitor. It's contraindicated with an older drug, atazanavir, that we don't see used very much anymore. And we should be monitoring it. It should be monitored with people who are taking ritonavir, cobicistat, and all the PIs or protease inhibitors. Again, efavirenz is another culprit. It can lower buprenorphine levels. So if you have a patient who you really feel like should be controlled at this dose, and they're taking their medication, and you don't have another reason, if they're on older HIV regimen, that could be a reason that they're having more symptoms. And then lastly was the naltrexone. Unfortunately, doesn't have any significant interactions with antiretrovirals, but we did find in one large study comparing extended release naltrexone to buprenorphine that it is inferior to preventing the relapse. So you're looking at benefits and weighing the pros and cons.
Well said, sister. So as she pointed out earlier, so providing effective substance use disorder treatment, which includes providing MOUD, is essential to achieving optimal HIV treatment outcomes. So let's talk about that. Why do you think that is? Why do you think one contributes to the other and vice versa? I've got my chat box open, so folks can feel free to certainly unmute themselves and give suggestions, or if there's any answers you want to type in. Why do you think these help each other out? Sister, this is what we call the echo pause.
I saw it means people are thinking. I like that.
Yeah. Yeah,
I
Shelby.
think that when HIV is properly treated, then and substance abuse disorders are properly treated, they help each other out, because when you're deep in addiction, you're not likely to follow through with medical interventions and take your medicine as directed.
Right.
And so it's critical.
Yeah, Shelby, so well said, right? It's part of a lifestyle or just what they're just going to be able to have the time and the wherewithal to be able to give time and attention to. So well said.
Yeah.
Thank you for that. Any other additional suggestions? Well, what we had pulled up on the list are a couple of things. What we know is that getting them into treatment for one healthcare need, the hope is that might start to increase their faith in the healthcare system in general. So if they're doing well in your treatment program, could that potentially encourage them to want to try out a different treatment program? We also know getting them into treatment for one healthcare need may increase the availability for the other healthcare needs. If they've gotten a foot in the door of this area of the medical field, is that going to increase their chances of a referral to the next one? Giving them a safe space to learn about harm reduction strategies might help them decrease some of their previous injection practices and other behaviors. And then also helping treat their opioid use disorder hopefully means that they can then decrease their opioid use and then therefore decrease their risks of HIV transmission. And make sure I didn't miss anything in the chat. Okay. So back to our program and back to sort of one of the topics of today's presentations, what are we doing to help our shared populations? So here's what we're doing in COAT, is that we offer HIV testing. We provide them a safe therapeutic space to process the news of that testing. We present them with education on harm reduction, and we do that at the individual and group level. And then when needed, we can make referrals to the Positive Health Clinic. What we don't do, Tony DiCiacchio and I were just talking about this not so long ago, I think we could talk about encouraging testing in a different way. The way the testing works specifically for our intakes is not necessarily an in-depth conversation, but more just sort of a check the box if they want it to happen or not. And I think there's more creative ways and more intentional ways we could have that conversation with them. We could also consider having specific group programming specifically for our patients with HIV, maybe also consider for Hep C, you know, how would they feel about being able to talk openly about that in the group space? And then we're not currently providing prep during code appointments. So these are things we got to honestly look at. What are we doing and not doing?
So at the Positive Health Clinic, we are able to coordinate our HIV primary care visits along with a wonderful psychiatrist that we borrow from Chestnut Ridge 2 days a week. We're also able to make additional referrals to behavioral medicine providers. We cover 33 counties in north central West Virginia. So from about Braxton County up in both panhandles, plus we have patients that come from Ohio, Pennsylvania, Maryland, Virginia. So we will refer for folks. Our patients that are stable with us often only need to be seen twice a year, but obviously mental health needs often require a lot more visits. So in order to try to minimize travel, we'll do other referrals as needed. And we also can provide referrals for therapy and have a therapist in the Morgantown area that we can refer to. Currently, our prescribers aren't, our providers aren't prescribing medication for opioid use disorder. We don't have therapy on site, and so we don't currently have a support group. We had one for years, but that therapist had to step away due to her own personal time constraints. So we're trying to find a new therapist to coordinate our monthly HIV support group meeting. So plug if anybody knows anybody.
So here are areas for future growth that we have talked about, again, and sort of working in conjunction with each other. And we'd be really interested to hear what are some areas that you see also. So areas for future growth, we could definitely encourage HIV testing at our treatment programs in a different way. We could work towards training providers to offer MOUD in primary health care. We could provide training and education to each of our departments. Any other areas you all see for growth, either in our clinic or in yours? Annie, sounds like we're solving all the problems here.
I wanted to say one thing specifically about testing, if I could, because it is something that I get questioned a lot about. For a number of years, there was specific HIV consent that had to be obtained to do an HIV test. That is no longer the case. So if you're at an agency and you're not quite sure, could we start doing more HIV testing? But I don't know about the consents and I don't know about the rules about that. There is not a specific additional consent that's required. It's best practice to counsel the patient on why you're recommending the person be HIV tested, but you do not have to have their specific consent to obtain an HIV test.
And what about for like billing purposes? Do you need that? You know, if we're going to be testing somebody for that and then therefore billing their insurance company?
Well, I imagine it would be either like screen for STI would probably be the first billing code that comes to mind, or then screen for, I think there's like usually a high risk behavior, which you could maybe call, or I don't know. I'm not as familiar with the substance use diagnoses. So I don't know if there are codes related to injection drug use or bloodborne pathogen exposure, maybe. I don't know.
I was more just wondering if we're going to be, you know, getting this consent for them ahead of time, because we will be billing their insurance company for it. So it's not necessarily something we want to draw for and send away without saying ahead of time, hey, by the way, we'll be billing you for this.
Oh, I see what you're saying. Yeah, I see what you're saying.
Yeah. Great feedback. Hold on. This comment I'd like to read. I truly appreciate medications for opioid use disorder being treated by a primary care provider have started to offer to manage mood patients as their primary care provider. Oh, I love that. Thank you. So one place that we can all start with today that's quick and simple is focusing on our language. So we know that examining the language we use, not just when we talk about our patients or talk to our patients, but when we're talking about them, that can be helpful in that destigmatizing process. I know we've looked at that from our addiction provider standpoint, but again, looking in both of our populations, here are some language that we can be thinking about. So if you think about us from our addiction provider standpoint, over time, you know, we've sort of gone away from using terms like addict or abuser to person in active addiction or persons who inject drugs. The sort of old language with drug screens was that they were clean or dirty. Now it's about a positive or negative urine. The sort of old way when talking about treatment is whether a patient was compliant with it, and now more about whether they're adherent with treatment. Sister, I'll let you take the back half of that.
Sure. So similarly, you would hear sort of language that did not center the patient or wasn't person first language, talking about people living with HIV. I refer to it as using the P word, right? Sometimes you'll see in notes that somebody will be described, a patient will be described as having promiscuous sexual contact. And I would say to them, like, well, what's the definition of promiscuous? Like, who gets to set that number, right? If it's less than this, it's that. And if it's more than that, well, then they're promiscuous. So just talking about multiple sex partners, and then just, you know, just describing whether or not the person used condoms or any kind of barrier protection. So yeah, just looking at language. It's really helpful.
Thank you, sister. I'm going to sort of skip over these last slides because we just have a couple minutes left. So yeah, as most of us know by now, we just have the potential to be so much more effective with their patients when we can talk about them from a place of compassion and empathy. Shameless plug for WV Medicine in Morgantown. My sister's over at the Positive Health Clinic. And she knows I always throw animals into my slides. And so here are our 2 outside farm dogs. And references. Okay. Oh, I need to stop sharing.
No worries. Thank you guys so much. That was wonderful. I love having both of you on here. And this is not related to your talk, but do you guys call each other sister?
We do.
Guys, my little sister calls me sister too. Like she's always, because she's 8 years younger, and when she was growing up, she couldn't say my name, so they would just say that's your sister. And to this day, my sister still says, "Hey sister, what are you doing, sister?" Like still talks to me like that. So I love that so much.
We are sister.
We just started that recently, though. We can't exactly pinpoint when that started, but it's been in the last maybe 4 or 5 years. Katie,
I blame COVID.
I think it was COVID.
I blame everything for COVID.
Sure.
Haley Palmer had a great comment. She said we were able to bring the Birch program to our rural clinic and have been successfully treating people with Hep C or HIV diagnosis. That is awesome to hear.
Great job.
That is great.
Awesome. Thank you very much. Great comment. So yeah, thank you so much. Does anybody have any questions or comments or any stories they can have?
Yeah, we didn't leave a lot of time for comments, but I will blame Jay for that.
Yeah, definitely, for sure.
I'll just say this. I'll just say the same at New River. I've been treating. I've been treating patients with Hep C, and I'm getting ready to be able to treat patients with HIV. And it's really gratifying and just makes sense. So for primary care providers who are doing that, I would encourage you to. There seems to be that slide about trust. There seems to be a trust level when people are in the MAT program, and you tell them you can treat HIV, or well, for me it's Hep C. They say, "Oh, okay." So
yeah. Oh, Jennifer, such a good point that they already have trust with you. And so for you to be able to continue that, yeah, that's huge.
Mm-hmm. And it's such a nice thing to offer people treatment for HIV or Hep C. We haven't done it with HIV yet, but people are just so grateful.
Yeah, I liked your comment that it feels so rewarding to be able to do that.
Jenny, did you have a comment?
Oh yeah, I was wondering if other clinics, because Katie's right, we just talked about this recently. I was bothered because we have like an opt-in approach to testing versus just automatically testing people that are coming in, because it makes sense, because these are high risk individuals. And I wondered if other people, how they're handling new intakes as far as screening for infectious diseases. Are you automatically doing it? Do you have a particular approach?
I automatically screened for HIV and HCV, but also I also was treated for the HCV. I haven't done the HIV, but for the hepatitis I have.
Helpful. Thank you, Sarah.
Yeah, we recommend people get screened at their medical intake, and as a result of our involvement with the Birch Project, we found out that people were not getting a number of people were not getting screened at their medical intake, and so we have a system in place that when they first come for induction, we make sure that that was done and recommend they do it if they haven't had it done. And because of that, we've picked up several people with hepatitis C.
Yeah, yeah.
We're also working with our local health department. I'm treating people who are part of the harm reduction program at the health department, so are still actively treating them for HIV or for Hep C. And that just started, and that's a very interesting project too, and gratifying as well.
Mm-hmm. That's great. What county, I'm sorry, are you representing?
Fayette.
Oh, okay. Great.
Great job. Thank you very much. Anybody else have any comments or questions?
Thanks, sister.
Thanks, sister.
I just have one announcement that the next time we're going to meet is going to be November 27th with Laura Lander discussing CPS involvement with patients. And I just hope you guys have a great holiday, whether or not you celebrate Thanksgiving, but just take some of that time and enjoy yourself and be with friends and loved ones and, you know, eat an extra piece of cake for me. So other than that, I appreciate you guys for all you do, and I will see you next time.
Thanks, Elizabeth.
Thank you.